Okay, thank you very much for attending this session of the webinars highlighting the use of the ML830 low power laser. We're going to talk a little bit about entrapment neuropathies, how they can be recognized, and to some extent about how they can be treated, particularly by using the low power laser. I'm Dr. Filner, and I practice in Rockville, Maryland. And we're going to start the webinar now. Certainly we want your feedback. There's a small box to your right on the screen that says chat. During our presentation, if you have any specific questions that you think might be relevant for most of the listeners, please feel free to type in a question and I will try to answer it during the webinar. If it's more of a personal nature in terms of a case or a particular problem or question you have about the low power laser, please feel free to contact us via the email address I'll give you at the end of this presentation and give us that feedback as well as any positive or critical comments you might have about the webinar. We want to continue to enhance your experience with your help. So we'll get started now on entrapment neuropathies. Just to let you know what my experience is, and you know where I'm coming from, that I was an anesthesiologist, board certified for 19 years, and my final appointment was as an associate professor of anesthesiology and head of the cardiac anesthesia program at George Washington University here in Washington, D.C. In 1986, I developed Meniere's disease and had to bow out of doing anesthesia. And Dr. Travell, who I had met earlier, and I'd been attending some of her seminars, suggested that I open a practice in pain medicine. And with her help, that's what I did. And I've been doing this for just about 24 years now. And I worked with Dr. Travell for about 10 years, where she not only helped get my practice started, but came here several times to make suggestions and often referred patients to me, and even gave me the honor of giving lectures with her at places where she was asked to make presentations. For the first 15 years of my pain practice, I developed a very significant skill in doing trigger point injections, and I did more than 250,000 individual injections. During the last 4 years, since I've been using the low power laser, the average of injections has dropped to about 50 per week or less. I think I now have only 3 patients who get trigger point injections. 2 of them because the workman's comp insurance company will only, or insurance agency will only pay for trigger point injections. They won't pay for use of the laser at this point. They are being penny wise and pound foolish, but that's for them to determine. At this point, I have done inactivated, I would think, more than about 120,000 trigger points with the ML830 cold laser, and it has completely changed my practice. This is the most important slide you're going to see today. When you evaluate patients with chronic pain, you have to listen to the patient and think outside the box. That is critical because very often the patients will report symptoms and you will detect signs that don't seem to make sense according to the ways you were taught 20, 30, 40 years ago. And what you have to do is say that just because that was the truth 30 years ago, it may not be the truth today. And you need to learn about this different approach to looking at pain in terms of myofascial trigger points. And when in fact something doesn't quite match what we think of as a clear radiculopathy or a clear carpal tunnel syndrome, let that idea seep in that it might be a myofascial pain problem, and you're going to look to see if that's the case. And once you develop that skill, a whole new world of treatment possibilities will open to you. Now, entrapment neuropathies, we're going to mention these 8 areas and show you how they occur and what you need to do to not only recognize them, but to begin the treatment of them. There's greater occipital neuropathies, the thoracic outlet syndrome, piriformis syndrome, pudendal neuropathy, the common peroneal nerve, entrapment by the peroneus longus, the tennis elbow, which is entrapment of a twig of the radial nerve by the supinator muscle. Carpal tunnel syndrome is an entrapment, and tarsal tunnel syndrome is an entrapment. Greater occipital neuritis, the symptoms are primarily headache, facial pain, frequently numbness or tingling on that ipsilateral side of the face in the C1 to C3 and occasionally into C4 areas. And they may also have burning pain in the occipital area where the greater occipital nerve comes out through this muscle noose that may be around them. You can see here, this slide, again, a lot of these diagrams were done on cadavers, and they do not match the reality of patients who are alive and kicking. The greater occipital nerve will be found approximately at the top of the ear and about an inch from the midline to the side of the lateral part of the midline. And right here you will feel a little depression on the skull, and that's where the nerve penetrates these muscles and then begins to go over the top of the head and down around here into the ear, down around here in the side of the face, into the C3 and into perhaps C4 areas. This diagram is slightly off, and you can see this neck is much longer than most. So it's been a little bit distorted. The muscles involved, which you need to evaluate and palpate to look for trigger points, are the splenius cervicis, the splenius capitis. This latter one of the hints you're dealing with this is the patient says they have pain on top of their head, and invariably if they say their hair hurts when they comb it at the top of their head, this is the muscle that's causing that. The upper trapezii anteriorly and posteriorly, the levator scapulae, the suboccipitals, and the semispinalis muscle. The primary referral area for semispinalis is into the occipital area as well as the forehead. And some of these muscles are the same ones that are involved in people who have been labeled migraine but aren't. Splenius capitis is here, right next to the facet of C2 or C3, and the referral areas are at the crown of the head and in the hair. Splenius cervicis, patient's referral is often right behind the eye. This is can be seen in all types of severe headaches. And be especially careful to look for the lower trigger point, which is frequently found just above or right near the top of the scapula, sometimes even a bit below that. This is the main referral area, but you can get pain up in this area, and some of these muscles here, this will often set off secondary trigger points here and entrap the greater occipital nerve. You can see the trigger points at trigger point 2 and 3 of the posterior trapezius. As part of the upper, and the lower will give you referred pain up into this area and set off secondary trigger points here that can entrap the greater occipital nerve, which is found just above this reference zone. Levator scapula refers either up or down, and again sets off or sets the stage. And you can see here where the attachments are. It sets the stage for the entrapment of the greater occipital nerve. So look there to the suboccipitals. There are 3 of them back here, and the trigger points primarily refer right above the ear along the temple to the back of the eye, but not this far forward usually, and may give you visual disturbances in terms of double vision or a cloudiness in your vision. That's often the suboccipital area. This is a good picture of the coronoid process of the mandible. Here is the temporomandibular joint, and the this looks like the internal ear meatus, and this jaw here, this is the way you can, right through this area here, if it's wide enough, you can see the medial pterygoid muscle. And if you do that and then come out and treat the lateral pterygoid muscle, and you can treat both the deep and the superficial masseter muscles, as well as the temporals, you can treat TMD significantly easier than you can with a lot of the injection techniques. And we can discuss that with questions if you're particularly interested in that. The semispinalis, as I mentioned, this one will refer pain to the top of the head, right into the area where the greater occipital nerve comes out. And this, again, is setting the stage here for abnormalities. This also refers to the forehead and will often give you symptoms that sound like migraine. Okay, let's go to the next one, which is the thoracic outlet syndrome. And the main symptoms, the patient will tell you that they have usually this numbness and or tingling in the 4th and 5th fingers of that hand, the ulnar distribution, and that's because the parts of the brachial plexus that will eventually become the ulnar nerve are the closest to the pectoralis minor muscles tendon, which is the, as we'll show you in one of the next group of slides, is the culprit in terms of causing this thoracic outlet syndrome probably about 95% of the time. If you try to elevate the arm just by laterally raising it, you will find that the radial pulse starts to disappear when the patient's arm gets about shoulder level or slightly above. That will tell you what the diagnosis is if that happens. The only way that can happen is if the pectoralis minor muscle tendon is tight. The patient may complain of a cold arm if the artery is compressed, a swollen arm if the vein is compressed, and they may notice that there's a different blood pressure in that arm when compared to the contralateral arm. The primary muscle involved is the pectoralis minor. This causes roughly 95% of the thoracic outlet syndromes that you'll see. About 2 or 3% are caused by an anterior middle scalene muscles being tight, and the brachial plexus itself passes through these 2 muscles and can be entrapped by these 2 muscles. The way to differentiate the 2 is that we know that the artery and vein pass under this tendon, but do not pass between these two muscles. So if the pulse is not affected and you don't have any coldness or swelling, then this is the likely site of the problem. This covers roughly 98 or 99% of the thoracic outlet syndromes that you will see. Rarely you will see a cervical rib or a very compressed first or second rib that can compress and irritate the brachial plexus that needs to be operated on through the axilla. It is big surgery and rarely resolves the problem, since it's primarily here at the pectoralis minor muscle. This is the pectoralis minor muscle right here, and you can see right here